technology challenges. The first thing is we're going to call roll. So Lori Goyette. Here. Mary Frost.
Here.
Carla Hosick.
Here.
Ruben Lopez.
Here.
Lisa Price.
Here.
Alex Ramos.
Here.
Christy Reeves.
Here.
Dr. Craig Ryan.
Here.
David Reeves.
Here.
Ms. Kathy Rogers. David Smith.
Here.
Ronald Stewart. In we're out. Lori Vincent.
Here.
Yeah.
Okay. Thank you everybody for being here. We have a full agenda for today. Where is everybody? It's usually one's crowded. So the first thing we want to do is talk about the rules. I know that we wrote the rules almost a year and a half ago. They're still in process. Jane, you want to give us an update on that?
Sure. The revision to the entire Chapter 157 has not gone anywhere since February. Session pretty much derailed us. We will be taking that project back up along with the suggestions that came in from all of the committees in September, and the staff of my groups will be working on those to bring forward a draft proposal. The draft, when it'll be ready, I don't know at this point in time. We really have to get back into it to see where we are. That's pretty much it. Questions?
I guess are we going to have to rewrite it?
Rewrite what?
I mean, should we revisit it? Because I think some of the things, there's some changes. Should we? I guess the question is, should we have a day meeting with the committee to look at what we wrote to see where we're at? Would you suggest that?
Well, when we have it wrote, it's not wrote yet. Okay.
It's still in the process of being.
It is in the process. I think the last time you and I looked at it is pretty much where we are, Jory.
Okay.
So there's still there's still a lot of work to be done on the level 4s. Let me go back and look at it and see. The plan still is the same once we have a draft, that it would come back through the committees after we've met with each one of the committee chairs and have gone through it and you're comfortable with it. You bring it back to your committee, you talk about it, you can make recommendations on it. Then we come together in a joint stakeholder group where all the committees or public can come in and review it line by line if we need to. And get everyone's input before it actually goes to the council for their recommendations up. So there's still a lot of opportunity for input at this point.
I think that's the real question. Okay. Is the PowerPoint set up? Nope. So the next thing we want to talk about is there has been discussion at the Pediatrics Committee of a position paper on radiological studies in the pediatric patient population. So they asked our committee to look at that position statement. So Lori, we're going to ask you to be the lead on this discussion.
Okay. Did they send you the position statement?
You're supposed to be able to pull it up. Well, they're pulling up. The reason there's a computer issue is because if it's on that computer, it's televised. Everybody gets to see the discussion. So there was an issue with the PowerPoint not being able to be sent from my computer to her computer. So the reason they wanted to take it off my computer is so that it could be publicized. So.
Well, while they're working on that, so the origin of the position statement was that there's a large concern about the radiation exposure for children, the cumulative effect over a lifetime, and of course the risk of cancer that this could cause maybe later in life. So there's concern that children are, there's studies that are done and children are transferred. Frequently those studies may not be sent. Sometimes studies have to be repeated. There's also no mechanism behind tracking their lifetime exposure. So knowing a child may have had several studies done at this age, for a later provider to have that information and maybe to rethink what their plan of care might be based on that previous exposure. So the position statements related to that and recommendations of, one, if you're transferring pediatric trauma patient, really consider whether you should be doing studies to begin with prior to transfer, especially if we're not going to intervene based on those studies. If you do the study, to then send it, make sure that it's sent, and then also to have some form of a tracking mechanism to know these children's exposure over their lifetime, and we have ability to look at that. A through F. Okay. Thank you, Sally. All right. So the position statement, which hopefully they'll be able to pull up. All CT scans on children should be performed using pediatric dosing reduced protocols. So everyone should have a protocol that uses reduced. And there is actually some protocols that are available. If you look at the Alliance for Radiation Safety and Pediatric Imaging, it's www.pedrad.org. B, avoidance of the use of protocols which automatically result in the performance of multiple CTs. That would be head, cervical spine, chest, abdomen, pelvis, and pediatric trauma patients. C, imaging modalities that not use ionized radiation such as ultrasound should be considered when feasible. D, understanding and linking guidelines of care that utilize evidence-based practice strategies which help minimize the use of unnecessary testing. E, avoidance of further CT imaging once the decision to transfer to definitive care is made, unless the accepting institution specifically requests a scan prior to transfer. If CT imaging is performed prior to transfer, the images should be included in the transfer documentation on disk or some other form of reviewable file. The final radiology report should be forwarded to the receiving facility as soon as possible. Acquisition of radiographic testing or delayed testing should be balanced against the risk of delaying critical care for stabilization of the ill or injured pediatric patient. And the final is F, accepting institutions should avoid repeating scans. Consider access to a cloud-based digital image translator.
You may have any discussion?
Do we know how many of our facilities, and that's what I've always wondered, are using pediatric dosing for their CT scans, the 3s and the 4s, the non-designated? If I could ask the audience, do y'all know if you're using pediatric dosing or no? I wondered if it would be worthwhile to maybe poll some of these facilities and see who is.
Another great, I mean, there's another great resource out there as well besides the PEDS-RAD, which is a website called Image Gently. It's Image Gently, I believe, either .com or .org, I can't remember
Can you
which.
tell me the microphone?
I'm sorry. Yes.
Really? You can't hear?
Not usually, don't have that as a problem. Image Gently is another website. It's got a lot of great resources. It gives literature, evidence to support practices as far as pediatric radiation studies go. It has templates and recommendations for your own protocol development and policies as far as studies with children go. It also has templates that you can use to teach families and parents what a CT scan is, what an MRI is, what those things are as well. So it's a great website and resource that people can definitely use to help develop their own protocols that are appropriate. I can say that just as surveying 3s and 4s, I do frequently find that they do have adjusted pediatric dosing in some of the facilities I've seen, protocols that they do follow. Some of them don't necessarily have it written up in a protocol form, but they can speak to what they use when they're doing pediatric studies.
Any other questions from the committee regarding the position statement? Is there a call to action on the position paper?
I believe it would be support of it. So I called that we support the position statement from the pediatric committee.
Is that a motion?
Yes, ma'am, it is.
And a second.
Any discussion from the committee members?
It'd be nice to bring back the information if we wanted to.
Do you want to do, okay. So any discussion from anybody in the audience?
I'm Sally Snow. I'm one of the members of the pediatric committee that helped work on this position statement. One of the things that I will tell you that we talked about yesterday afternoon is disseminating this position statement so that everybody has an idea what it says and everybody gets the resources. And we are also working as a committee on some strategies to help get that done. So more to come.
Thank you. No other discussion? All those on the committee that are in favor, please say aye.
Aye.
Anyone opposed, please say aye. Motion passes. I just wanted to back up. Is Tammy Sajak in the room?
Right here, Joe.
Tammy, do you have anything you want to give for that survey, update on that survey that you did?
I already did, that was quite a while ago.
Right. Any feedback or anything on the survey, comments? Okay. Just want to give you the opportunity. So now let's talk about some of the new issues. So at the last committee, if you remember, we talked about the geriatric, the TQIP protocol that was, and the resources that were put out. I shared that with the committee members. And so here are some of the recommendations. Now, IRAC is looking at adopting these. So if you, again, it's the CDC field triage guidelines, the blood pressure of 120 in the geriatric patient population. And so there's very strong evidence if they're 65 and older that that's shock. Now, a lot of people ask me, well, why not younger? Because some people, you know, have evidence of that. When you look at the literature, there's clearly there's been research that can support the 65 and older. There's still some data opportunities for the less than 65. So the question is the consideration if the patient has multiple system trauma, their geriatric can have a BP of 120, whether or not that patient should go to the highest level trauma center in that region. And if the patient has a blood pressure of 120 with a single system injury, transport to the closest, most appropriate trauma center. So that's the field triage recommendation. And then on the hospital recommendation, that the blood pressure 120 would activate, and multi-system trauma would be activating your trauma system as appropriately as a high-level activation, and a single system with blood pressure 120, which is shock, would activate a tiered response based on what the trauma center has. For example, Parkland has 3 levels, level 1, level 2, level 3, single system injury trauma, 65, blood pressure 120 or less. The question is whether or not that should be a level 3 or level 2 activation. So in addition to that, the hospital trauma activation would have to include that. And then some of the other things to discuss would be, when do these patients get included in the registry? Clearly, if there's an activation and they're admitted by the trauma surgeon or a specialty service as part of the trauma service, they should be included in the registry. Then we hear questions about, okay, I'm not going to admit this patient, but they're going to be on the hospital service and I'm going to continue to see this patient and may take the patient to the OR, then yes, that patient should be included in the trauma inclusion criteria. But probably the most controversial thing that we see or hear is they're activated, the trauma surgeon or the physician sees the patient, they're sign off on the patient, they never see the patient again in the hospital, and the recommendation is that's not really a trauma patient. It would be just like any other patient that you send home, and they would not be in the trauma registry. So those are the recommendations, but you know, to move forward, we at the last committee approved to develop a trauma medical director best practice work group. Brian Eastridge was charged to be the chair of that group and to bring together a group of individuals to be on that committee. And so my recommendation is that they take this and work with this and come back to this committee. But I wanted to make sure everybody kind of saw what the potential recommendations were. So I wanted to open that up. Does everybody remember that TQIP booklet that we handed out with all the recommendations in it? Any thoughts?
I have 2. The first one is you're using, I agree with 65, but you're using 120, and that's only for criteria for transfer. What is a primary responder going to do with an elderly patient with multi-system with a blood pressure of 120, are they going to treat them the same way that they would on the patient that has class 4 shock? So that's the first question. And the second one is the last one about the surgeon signing off. Usually after 24 hours, we sign off if there's no other issues. Now, are those patients not eligible for the registry?
Yes, if you admit and you're continuing to see the patient, then yes, it's a registry. We do that every day, right?
Right.
They would be in your registry, but probably the controversial issue that you see and you hear is, I saw the patient, I signed off on the patient was admitted to the hospital service, and then they're included in the trauma numbers. That's probably not appropriate.
If you sign off immediately, I agree, but if you sign off within 24 hours, it should be okay.
Right, but I think the clear communication is if you admit the patient, trauma admits the patient, specialty service goes into the registry. If the patient is admitted and the trauma service, specialty service continues to see that patient, which is what you're talking about, goes into the registry. They see the patient and say we're not going to admit this patient. We're not going to see the patient in-house. It's going to be admitted by this other non-surgery service. Then that is not a trauma patient any longer. That's pretty much the standard right now.
Does the ACS agree with that?
Any patient that you sign off in the ED, yes. You have to sign if you're signing off in the ED, not upstairs in the ED. There's not any difference in any other patient.
If a trauma patient comes in, regardless of mechanism, and we feel they need to be admitted, a trauma surgeon is supposed to admit the patient, period. And then appropriately sign off within 24 hours if they're going to be staying in for some other medical reason. So to me, it's a non-brainer. So the controversy is, I guess, just to be specific, is if you sign off immediately, then that's no good.
There are a lot of trauma centers, and I'll ask some of the site surveyors that do this, there are a lot of trauma centers that see the patient, work the patient up, and then they sign off in the ED. And sometimes when you're reviewing hospitals, they're including those patients in their numbers. They're not really trauma patients any longer. But it's very different if you see the patient, work the patient up, decide to admit the patient into the non-surgery service, whether it's the hospitalist or medicine, cardiology, whoever it is, and a surgical specialty service is continuing to see the patient, whether it's 24 hours or 2 weeks. Those are still trauma patients.
Jory, I'd weigh in on that. I'm actually more concerned with the lick and a promise approach of a trauma surgeon looking at the patient, deciding there's absolutely nothing wrong, and walking away at that point in time. If they've had a significant traumatic mechanism, I think every trauma surgeon in this room has seen patients that looked perfectly fine when they got to your ED, and the next day they didn't look perfectly fine, and some of us have even seen some of those folks come back in with subdurals and delayed identification of ruptured spleens. All kinds of things can happen in this geriatric population. I'm much more concerned with the trauma surgeons just giving it a once-over and walking away if they've had a significant mechanism. And I agree there ought to be at least a 24-hour, and I imposed a 48-hour rule on my trauma surgeons saying that they were not allowed to sign off for the first 48 hours so that they would not miss those occult injuries. Now, 48 hours may be a little aggressive, but I think at least a 24-hour rule before they're allowed to be put in the registry would be appropriate. And I think a trauma surgeon needs to stay engaged with them for that period of time.
Right. Let me just give you scenarios to help kind of make this more clear. So the patient that I'm talking about, the trauma surgeon sees the patient and they say, I'm not going to admit this patient, I'm not going to continue to follow this patient. Somebody falls at the nursing home. And so they come into the trauma center, they work the patient up. The patient has dementia and advanced directive. They don't want operative intervention. The surgeon signs off on that patient. The patient is admitted by the hospitalist service. The surgeon has said, I'm signing off. That's the patient that we're talking about. So The other scenario would be the patient that comes in with the bump on the head, you do a CT scan, you say, I'm concerned about it, I want to rescan in 12 hours, you put the patient upstairs on the hospital service, the surgeon continues to see the patient, and then 24, 48 hours later, there's no sequela, the patient is signed off. That patient should be in your registry because you admitted it. The other patient, the question is, do you put that patient in the registry? The one you saw in the emergency department and you signed off, and they were no other contact with the trauma program. They weren't in the registry. Your trauma nurses are not seeing the patient every single day. It's a sign off from the ED.
And my answer to that question, the way you posed it just now, was no. Those patients do not belong in the registry if there was absolutely nothing wrong, and the mechanism of injury was such a low kinetic force that they're not likely to have anything develop. So I would not, and we don't in my institution, put those patients in our registry or make them bona fide trauma patients.
You know, it's funny because if it was an adult patient population that you saw, I think every trauma center in here, if the surgeon sees the patient and says there's no injuries, I'm going to discharge the patient, there's no question of whether or not that patient goes into the registry. But in the community and trauma in Texas right now, there's a tendency to question whether or not it conclude that geriatric patient. If you're going to keep the patient, follow the patient, plan on operative intervention down the road, going to do something else in-house, keep the patient, yes, clearly that's a trauma patient. But if you're signing off in the ED, my question is, I don't think that's a trauma patient. Just like the 22-year-old you sign off and send home is not a trauma patient. So that's the question.
What about the patient that comes in that clearly has a trauma diagnosis, but the family says they absolutely refuse any intervention? Should we include those? Those are getting to be a bigger problem, at least in my house.
If you don't follow the patient every single day, or you're not going to see the patient upstairs, then I don't think it needs to be in the registry. Questions? We're not going to make decisions on this because we're sending it to that committee. I just wanted to make sure everybody in the group is involved in that type of discussion. And you need to go back and look at your own hospital and ask those questions. From an injury prevention standpoint, good to have that information. We actually, every activation, put a minimal data set into our registry, whether they go home or they stay. For every activation, that's a different type of tracking system. But the real issue is, if you look at the geriatric patient population, I think the thing that's concerning is, if the patient was 12 years old and you sent the patient, you signed off in the ED and sent the patient home, they don't go in your registry. If they're 22 years old and you see the patient and you sign them off, they go home or to another service in your hospital, you don't put them in your registry. But there's a tendency with this group for some reason to put them in the registry. Now you have an opportunity to skew the data that we're actually pulling out of the registry to look at. So if we're going to do it for one patient population, we should probably do it for all the patient populations. And every trauma center out there today can make the decision that I'm going to include the minimal data set on every activation. That's a hospital decision. That's absolutely a hospital decision. But the question of, are they considered a trauma patient? And I'm going to put them in the registry, send it to the registry data, goes to the state. That registry data at the state is also used for 3588 and other things. That's the question that I raise. If I sign off on the patient in the ED, is that truly a trauma patient that we're going to continue to track in the registry?
My only concern would be that trauma patient that you sign off on that isn't clearly a do nothing. And the missed injuries. How are we going to track that missed injury? Which is the problem I think Craig is almost referring to. Is that you go down and say, no, there's nothing wrong that I can find, but if you ask the family and they said something, if something was wrong with grandma, we'd want something done, those would be the only ones I would be concerned about.
My question to you is, how do you do that for the 12-year-old and how do you do it for the 22-year-old today?
If it's a 12-year-old, they're clearly tracked by their parents. And people falling out of nursing chairs or wheelchairs at nursing homes, I don't think they're tracked quite as closely as kids because they're falling out of, if you turn your back on them, you fall out of a wheelchair, it seems. It's the silver tsunami.
Well, So I guess the question is, does the committee support sending this to this practice work group, the evidence-based practice work group that Brian Eastridge is going to chair?
Absolutely.
No. I mean, I agree. Send it. I have no
Yes.
objections.
So that, there will be a work group and there'll be lots of healthy,
Yes.
controversial discussion. I'm counting on it.
I think that we have to do that. We need guidelines for this.
Okay. So something happened to the computer here.
I just hope Brian puts more into it.
We talked about the geriatric, the registry work group. We met today. So the opportunities for the registry work group, we looked at these categories. We're continuing to look at these categories. Implementation. Implementation includes communication, education, and resources. What do people need to know and understand about the registry? Operations, data entry, mapping, vendor discussion, and then reports from the stakeholders. So we asked for the top 5 reports that you wanted. So we also talked about rehab and disaster. Those are the standard agenda items. So today, we didn't hardly even touch on some of these, but I'm going to share with you some of the things that we did decide. I think it was a good meeting. So, we're going backwards. Somehow or another, we have the old data up there, not the new data. Oh well, so much for that. So the question is, in the new meeting today, the thing we talked about and the action items were NMSIS. So Preston Love and Brian were asked to look at the NMSIS data to define the variances, right? Then the next issue we talked about was the National Trauma Data Bank. They have a dictionary for year 14. So Irene and Garrett is going to do a comparison for where we're currently at and going into the 14 database. Then one of the big things we talked about today, this was Brian brought it up from Houston. It was created great controversy, is the linkage of the patient. So in the beginning development of the registry, there was a strong component of silos. So the silos are hospitals have their database and nobody's going to access it. EMS has theirs and not going to access it. No one else can. So we all heard about this patient-centric issue that you could cross the line. So there's some controversy about what cross the line means and being able to go into these databases. So today's discussion identified that in the current development of the registry, there is not an opportunity to cross over. So it's important everybody understands what that means. So if Dallas Fire Department brings us a patient and we enter that patient into our registry and we send it to the state, Dallas Fire can't go into that database and see any of that information. So just like I can't go into Dallas Fire and pull out and look at any of that information. So when you look at the realistic issues of that, the controversy came up with, well, why can't I look at that basic demographic data for each facility, from fire to the hospital, hospital back to EMS? And so I guess, I was sitting there thinking, I thought that's why we hired this vendor, to get this patient-centric database versus the thing that you could buy off the shelf. So in today's discussion, the group agreed that there should be a way to share data between EMS and the hospitals as long as we define what data elements are going to be shareable. So Tammy and the vendor are going to come back to us at the September conference call and give us some feedback on that. Okay? Any questions? Mary, you weren't there?
Well, yeah, and I had talked to somebody about it, and I thought it was intriguing that if there could be just a small data set that they could see that would be meaningful to them, that might be
I think
workable.
the controversy is this. We have hospitals that are going to do their data entry and use that registry every single day. those hospitals want to be able to use it for their PI. So when people say I don't want anybody looking at my data, I think they're trying to talk about the protection of performance improvement measures. I don't think anybody even thought it meant that you can't look at demographic data. Or the example from pediatrics, I'd like to know how many times this child has been injured and taken to other hospitals. So the recommendation was to try to move in that direction and to identify the data elements that support that opportunity. So, any questions? Anybody in the registry work group that want to make a comment on that? No. Okay. And then the other opportunity was we asked people to identify the top reports that they wanted. So people sent in a mixed match of type of information. So we recognized in asking the question in that way, we probably didn't ask it detailed enough. So Kelly Stowell from Temple is going to write a little template for you to request and tell us what type of questions that you're asking that you would like to get data to answer. So Kelly's going to do that. And so that's the summary of the meeting today. We feel very good about moving forward. We're on the right track. There is some data that we're going to show you. So Colin.
Yeah, sure.
Hopefully this computer will work.
I'm just going to shut this down and pull up the PowerPoint. So essentially, and Jane can potentially back me up here, when we looked at the top 5 reports at the DSHS, we were pretty confused by what we saw. There seems to be a jumble of everything. And until we were able to really ask ourselves what folks were really wanting from those top 5 data points, until we were able to define it in an area of a question. And these are, I think, the questions that we're all trying to get the answers to. What are the leading causes of injury by RAC? This is just an example of 2009. And then the leading causes of injury, morbidity, and mortality by RAC. I think everybody's top 5 data points falls within these 2 categories pretty broadly. And John Helstein at the last GTAC from the Trauma Registry Group basically said that if
Shoot it.
Don't tempt me.
John Helstein basically asked folks to really define what the research questions were in general, and then it's going to lead us to these big questions, these overarching kind of umbrella questions, and then from these things we'll be able to tell, we'll be able to pull out these individual data points. And so I think that was the overall point here, going back to this idea of developing great research questions. Which one of you was going to be responsible for that? No? Oh, there you are. Okay. Yeah. So we're going to work on that, and then I can work on that with RACs in general too, is really refining those research questions to get at all of this and those top 5 points. Jane, is there anything else?
Yeah, I think one of the things that we talked about is that when you look at information like this, you say, well, I want to know why are the motor vehicle accidents in this RAC, why are they so high? So any of the data elements that are being collected, you can continue to drill down and further stratify and get to some of those answers. So if it's geocoding that's there, if there's, was it in a motorcycle, was it a car, whatever it is, this is just a starting point, and then it can be drilled down. And I think that's what we kept hearing from the members that were trying to identify what they wanted, is we got all of these data elements. So we can stratify by age, you can location, was it fall, was it whatever's collected, you can get it back out. So John Helstein is going to help us with that. He is is John here?
He's an engineer.
Right, I was going to have him stand up. He's not here. Okay. So he was going to help us with some of those, developing those questions and bring us back some starting points. That's kind of where we are.
I don't know about anyone else, but I can't see what those boxes are.
I'm sorry,
So
here.
if you
Let
could
me-
explain what we're seeing,
Yeah,
that would be
so
great.
this very top light blue is motor vehicle crash, followed by that pink is suicide, then falls, the purple is poison, and the red is homicide. So,
So Colin, I received an email that says, hey, we can't read it from the audience.
well,
Can you send it out?
and
so
this
we
wasn't
can read it?
intended to be done here. It was at the trauma systems group meeting.
Where did you get the data? Each RAC gave you this data?
Tammy?
It's vital statistics unit data.
Because on my RAC, that doesn't make any sense. That's
Okay,
not right.
yeah. This is, I'm just saying that this is, I'm not speaking to the actual validity of what we're seeing here. I'm using this as a point to say, these are the kind of broad questions that we should be asking ourselves to really drill down into each issue. And until we ask the broad question, these individual top 5 reports that we're all requesting don't make sense. I think we have to frame it in the context of these 2 questions. What are the leading causes of death and injury per my region?
Before you even ask that question, don't you want to know if the data is even right?
Absolutely. Yeah, no,
Because it's not.
I agree with you. Okay. Yeah, no,
Let me help you out a little bit, Colin.
please.
If you go to the injury website, the data is correct, and it's also divided out by the 3 separate data sources. Colin was just trying to show you a picture, so let's just not think about that for a minute.
Yeah, let's
because-
not concern ourselves with
Yeah,
the validity.
the data that
validity
is
of
on
this.
our website is in a table,
Yeah.
most of it. And so he was just showing that it's better when you show a graph to people. It's sometimes better to display the data that way. But if you're trying to think of what your questions are for your particular trauma service area, if you go to our website and you look at the 5 leading causes of death and morbidity, they are by trauma service area. One set of data is for the vital statistics death certificates. One set of data is for the trauma registry. And one set of data is for the hospital discharge data. And that will help you to see what's going on in your particular area and maybe give you some ideas of what you want to know more about on that particular thing.
Which doesn't right.
Does that help a little bit?
No, because the data's still wrong.
Yeah, I know.
I mean, if you go to my RAC, you'll find that the data's wrong, but if I go to your webpage, it may be right
It
to
is
you,
right.
but it's not.
On our
I'm
website,
telling
the
you,
data's
it's not.
wrong. The data what we have on the website is what was reported to us. So if we have incomplete reporting or if the data is inaccurate, then that's what it's going to reflect.
Right.
Now, we know that the death certificate data is usually pretty high standard of data, so there's usually less error with that data, so that might help you to think about that when you're looking at just the death data itself. But if there are things that don't make sense to you, and you say, well, the data says that, but I don't really think that's what's going on in my area, that's a good question to ask too. Because then we might want to be looking at things that we can compare to each other. Well, it was higher in the hospital discharge data. Why was it higher in that data than it was in the trauma registry data? Things like that. So I think looking at the different data sources might give you some questions to even question the actual accurateness of
Absolutely.
the data itself. So those are good things to bring forward. You know, say, I don't understand. I know homicides are low in my area, but they're high on this graph. What all went into this homicide number? You know, those are the kind of questions.
Colin, do you want to go over the RACU project?
Sure, I can do that. We are currently in the middle of the RACT pilot project with the folks in Abilene. It's a partnership between the DSHS, our side, EMS Trauma, and the trauma registry folks and RACD. The goal of the project, again, is to determine what the existing barriers are or the perceived barriers are to trauma registry participation at RAC level. We started that with a survey in June. That kicked off on the 15th. It closed about the 1st of July. On July 17th, we all met, trauma registry personnel, folks from our office and RACD stakeholders met in Abilene to discuss the results of the survey and make sure we got it right. And then Tammy Sajak and Rob Klein took over the discussion and started to talk with stakeholders about the actual issues and actually gave a pretty, I felt, valuable demonstration on site there of actually going through a few of the issues that stakeholders had. Excuse me. Over the next 45 to 60 days, Tammy and her folks, I think, are going to be returning there either on a one-on-one basis or a small group basis to continue to troubleshoot issues. And we should have a full wrap-up report by next GTAC on that, what the overall results of the survey were and kind of some best practices takeaways from the process. Are there questions about that?
Garrett, do you want to go over your data?
So as part of the registry work group, the Texas Trauma Coordinators Forum Trauma Registry group has had concern with the registry regarding ISS calculations for the small facilities, 3s and 4s, because the new MAVEN system doesn't calculate ISS scores. So we took the public use data file set from the state for 2011, which is the most current 2011 emissions, the most current clean data set that we had available. And we wanted to see prior to MAVEN what we had. So we created this length of stay and injury severity report based on that data. And so we broke it down by trauma service region. So this is just a breakdown of length of stay, total admissions divided by hospital days to get your percentage or to get your average length of stay by RAC. So that's the quick length of stay. But really what we wanted to focus on was injury severity scores and ISS by RAC. So here's a breakdown of missing or not reported records with an incomplete ISS score, meaning it was not scored. And this was in the pre-MAVEN system where it actually calculated the ISS score for you. In the current MAVEN system, what we're hearing from the level 3, level 4 centers is they're not even putting in ISS because it won't calculate. They don't know how to manually calculate. So we got data pre-MAVEN. It's going to be interesting to look at the data post-MAVEN and then work on a solution for those small centers that are manually entering data. But we also learned that there was some potential education and other opportunities from looking at this as we go through the RACs. For example, RAC A. We like to see a normal progression from the 1 to 2 down to the greater than 24. We shouldn't see spikes traditionally. I mean, we have to dig deeper in between, but as you just go through here, here's one RAC B where there is that nice progression down. But then we see some like this, and there may not be a level 1 or level 2 trauma center in that region, so that might be appropriate for that to be reported for that region. But we want to drill down in the data a little more and see if there's education opportunities or if there's ways we can improve the new registry system for ISS reporting. So
Anybody have any questions for Garrett? I don't think he said this, but he said this in the other meeting, that there were 7,000 records that did not have ISS scores in them. So that's a huge deal when you think about how we're trying to use this data to make decisions, to move forward. So there's clearly some opportunities to work with the registry vendor, but we also have to figure out other ways. As Brenda pointed out in the meeting, the turnover rate in the level 3s and the level 4s is pretty significant, more significant in the level 4s than the 3s. So how do we get that information to them, keep them current? The other obstacles and barriers that we all know about is that the AAAM injury severity scoring class, which is the hallmark for that class and that training, creates a barrier. And the barrier is that the class is $700 to register. The second barrier is that it's usually offered in places not in Texas, which means there's additional travel dollars. So, you know, one of the things, if we could figure out how to get the class in Texas more frequently, that would be the most optimal situation. So there are some issues with the injury severity score that we're going to try to figure out. We're going to ask TTAF's trauma division as well as the Texas Trauma Coordinators Forum to work together to come up with some potential solutions for that. Because the questions, and I don't know, Donna, if you want to, Brenda, want to stand up. We talked about the data management course that TTAF has offered and whether or not there's a role to help with that. The problem is that you have to be real careful with the ISS because it's copyrighted. So there's a lot of issues with that. Brenda, did you want to make any comments?
About the data management course?
About the ISS training?
Yeah, we tried to bring in several courses in the last several years. It is very, very cost prohibitive, especially if we can't fill the class. We have to pay up front for the class.
Yeah.
And all the course materials, and then if we don't fill the chairs, it's a great loss for us. So financially, it's difficult to do. We had hoped to fill the gap with the data management course, although we are not able to provide the training on the scoring due to the AAAM has approached us back and forth. We're been working on an alternative option for that.
So through TTCF, we are not working on an AIS scoring course at all, but we're going to work on an ISS manual calculation course. That's public information. Everyone can learn how to manually calculate an ISS score. We just cannot teach them how to code AIS codes. But you have to have an AIS code to calculate an ISS score. So we can show them the code, tell them how to use the code, like what the elements of the code are, basically the anatomy of a code, which number you use to calculate the ISS score, but we can't tell them how to actually code AIS coding.
Gary, I was just going to make one comment. What you see a lot of times in small facilities, other than the very frequent turnover, which is problematic, is that a lot of these folks that are doing the coding are not even familiar with the process of finding the injuries. They're using whatever their hospital coders use for billing, and that's the only thing that they try to use for their code. And then the Maven system, although I'm not as familiar with it as others, there's barriers, as we know, with putting that, because then they're trying to manually put in these codes. They don't know what they're looking for. So even not teaching them how to score, because we don't want to trip on the AAAM, but just to explain the process of going through the chart, where to find the data, what things can be included, is very important, because I don't think they understand that.
And I think that's through the TTAF data management course is really where they will get that experience.
I think from a systems perspective, the most optimal situation would be if there was a way that the level 4s could capture the right injury severity description and then run it through some database, either at the RAC or through a big sister hospital, so that it's calculated before it goes, or the state calculates it. Because long-range strategically planning, I am pretty sure no matter what we put in place, this is going to be an issue. So I think long-term we need to look and see if there's a system-wide opportunity to put a stopgap in there so that all records go into this facility in Iraq, or all records that don't have ISS scores go into a system at the state, so that there's accurate calculation. If we're going to use this data to make decisions, we need accurate data. Anybody have any thoughts?
So I think there's an opportunity where we could work with Tammy and the state to develop workflows to potentially help train or review those accounts that are being submitted without an ISS in the new system. I don't know, Tammy could probably speak more to that, but there probably could be an opportunity where we could develop some sort of system, and then also just to mentor or monitor those accounts coming in with a new coder or trauma manager on it. I'm sure with the Maven system you could develop something, but I'm not that familiar with workflows.
Thank you, Garrett. You want to comment, Tammy?
Yeah. A workflow is a way to flag something that needs to have some activity done to it. And so it's sort of like a report because it'll gather all of the cases that you told it what criteria you wanted it to flag and put them into basically like a list for you. So if we said we want you to flag all of the records that are coming in without an ISS score and put them in a workflow, then when you open the workflow, all of those records are in there as a list so that you can easily then share that workflow with other people who need to access whichever cases are in that list. And it could also be set up so that you run the workflow by facility so that you're just allowing that particular facility to access their own workflow for their own cases. So that would be one idea for how that would work. So I'm just curious, like what you were saying about using the billing codes to try to find the injury codes, and then when they're doing the manual data entry into our system, and it's built for all those drop downs to try to find the big category of what type of injury it was, and then try to drill down and stuff. And I'm just thinking if they're having a hard time with just the code for what the injury is itself, then what do you think they'll do as far as trying to find the abbreviated injury score that would be associated with that?
I think it's extremely difficult. I know that a lot of different types of software packages that are already out there have the ability of just typing in the diagnosis and it codes it for you. And that's a lot easier system, especially for a person who's not familiar with that, than trying to figure out all the AIS and pre-dot, post-dot, and all this stuff.
And it's I think, having looked into it a little bit and read some of it, some of those systems are paying the AIS people thousands of dollars in order to be able to incorporate that into their system, and it's kind of like an annual fee. So that's one thing that I can get more back with you on that. But at one time I had looked into it, and that was the case. It's hard for software developers to develop something against that proprietary software that they have.
It's about $3,000 a year.
Is the ISS category mandatory at this point in time?
ISS is, yeah.
We talked about that a couple of days ago.
It had, in some build of the system, the ISS had been somehow left out as being a required data element, and then that was changed once it was recognized again.
I mean, I think the ISS is one of the critical things, because if we are ever going to be where we can benchmark our hospitals, our systems, our state against others, that's the hallmark for benchmarking out there. So if there's a way for us to figure out how to create a workaround, we probably should do that. Okay, so at the last meeting there was discussion. We showed you some data from alcohol-related injuries, specifically showing you some information that was captured out of RAC-E, looking at the holiday season. And so we asked the group if there was a desire to try to get that information from the state's perspective. And so to get the state data, we need to find out who's actually capturing that data. So Carla and Christy and Kathy Rogers were gracious enough to take this on and develop a survey. So they're going to show you the report. Christy, you want to start?
Yeah. So we sent out the survey in July through TTAP, and we gave the hospitals a couple weeks to respond to that survey. We got 146 responses from all the different trauma designated facilities in the state, out of 267 facilities. So we still have a lot of facilities that weren't either able to get the survey because of a firewall at their facility or with TTAP. I think there were some issues there. Anyway, as far as percentages, it comes to about 55% total of all the trauma centers in Texas. And then we broke it down by designation level and the amount of times that that facility had been designated before. So the blue you'll see is facilities that had been designated less than 4 surveys, and then the orange is greater than 4 surveys or redesignations. And so first we asked if they're able to actually perform a blood alcohol level at their facility, because I was kind of surprised to find that not everybody can do a blood alcohol level at their facility, and they have to actually send out those tests, and it may be 24 to 72 hours before they get those results back. Then we asked them if they perform blood alcohol levels on all trauma patients, and this was our response. Of course, we had a higher response slightly from the level 1s and 2s, but we were still pretty surprised at that.
We had 2 facilities that identified themselves as pediatric centers, and so that played a part in their responses. So if they didn't identify themselves as a pediatric center, we didn't differentiate that data. But I was surprised by this data that only 10% of the 1s and 2s perform the blood alcohol on all trauma patients that are seen in their ED. I was pretty surprised by that. 0% of the level 3s. And then again, does your hospital perform blood alcohol level on all trauma activations? I was also surprised by this, thinking that it would be a standard for trauma activations, and it apparently is not. So for level 1s, only 18% perform blood alcohol on all trauma activations. And I had to go back and do a hand count because I was surprised by that. Rather than create a slide for each response, it was quite a variety of responses for why they didn't perform blood alcohol levels. So we really just listed the most frequent response, and most frequently it was not clinically necessary as the reason they don't perform it. Another significant reason was reimbursement and cost issues. And then a good majority said that it was the physician who makes that decision. So if the physician didn't think it was necessary, then they didn't do it. Basically, that kind of goes with it's not a standard. If they're a pediatric facility also, they don't do blood alcohol screening across the board. And then lack of lab equipment and send out testing. So after we looked at this, we developed some basic recommendations. After creating this and gathering the data, we discovered that there was a potential firewall issue, so maybe the facilities who didn't respond didn't actually have an opportunity to respond. So we thought maybe we could send it out and gather more data, see if we get more response, and then provide education. Some of the actual responses of why they don't do it is it really led to what I think is a misunderstanding on their part about legal blood alcohol versus medical blood alcohol levels. Some of the responses from 3s and 4s were that if law enforcement wants it, they need to draw it, and really there's a significant difference. So you would draw it as a facility because it's medically necessary for the care, if the legal blood alcohol is a separate process. So maybe some education there. And then also education between the relationship between identifying a patient who's under the influence with the driver responsibility program and trauma center funding, and how all that ties together. That may be helpful in the blood alcohol screening being a standard. And then an investigation on insurance payer and payments. Now, Christy has done a little bit of research in the last day on this. And so, Chrissy, you want to just talk about what we looked at?
So I researched to see with Medicare if there was a certain rule or law or whatever regarding their ability to deny payment based on the patient being positive for drugs or alcohol in their medical history. And we came up with actually a report that showed that 26 out of 50 states allow insurance companies to deny payment based on that information. The other 24 states do not either allow it or they don't have a law one way or the other. So I found that very interesting because I knew we had heard of some cases, but I didn't realize that there was something that actually addressed that specifically. And we were able to pull up some of the Medicare rules and regulations on the ability to deny payment based off of that.
What about Texas?
Texas?
Yes, I'm sorry.
Texas has the ability
Texas
to
is one of the ones that does allow it.
Does allow the
Yes.
denial.
Texas is one of the states that allows the insurance companies to deny payment based off of that.
We actually had a patient at our facility that, although they did not deny, actually it wasn't our facility that treated him initially, although they did not deny the emergency room visit and the inpatient visit, they denied the rehab. The family had to come up with cash for any rehab because it was alcohol associated.
Anything else, ladies? No. Great work. So what does the committee want to, they had some recommendations for us. Any thoughts? Next step?
Kathy isn't here, but one of her suggestions was that maybe we collaborate with TTAF to see what kind of education we could develop and come up with and send out.
As far as the legal,
as far as what the law is and differences and just overall general education about it and how essentially addressing all the bullet points underneath the education piece, but that's up for discussion. That's what she would wanted to say.
So Ms. Welch?
She's hugging the wall.
Ms. Welch, you want to repeat your recommendation?
Kathy Rogers recommended that we collaborate with TTAF to develop some education that can be given to the facilities regarding blood alcohol screening.
We will absolutely work with this committee and Kathy on that and see how we can best initiate that.
Great. So I guess if you go back to the original question, hold on a second, is whether or not we want to try to capture what data we do have to look at the holiday alcohol-related issue. So are we going to put that on hold till we get more information? Do we want to kind of move forward?
I have a question. What is our stance on this? Are we wanting everybody to do it from an injury prevention standpoint, or if it's not medically necessary and doesn't change your treatment, educating them to the laws and those kind of things isn't going to change whether or not we do it or not? I guess I'm just more curious, like, what is our stance on this?
Well, I'm not sure that we have a stance on it. I know that if you, for the level 1s and level 2 trauma centers that are required to do the expert training, I was shocked that people aren't. It's not mandatory, and they're not doing it on every patient, to be perfectly honest with you.
Well, we're asking the questions. You know, the expert, I mean, they ask the questions, and we don't 100% test everybody.
So I guess we need to take that back to the work group, because, you know, if we really want to drive the system with data, you need that data. I'm not proposing that every patient have to get a blood alcohol either.
Well, we also have a barrier, some of the 3s and 4s, this is a send out for them.
Right.
So that's a barrier too, to really it being valuable or information they can even obtain.
They can't obtain, they have to send it out though.
No, I know, but I mean, if the patient's going to be discharged or whatever, I mean, it's not going to necessarily help drive what they're doing.
Right, it's not a game changer for many of those patients. It doesn't make, that piece of information isn't going to help them make the decision of, are we keeping this patient or are we transferring this patient out?
Correct.
And having that capability is not a requirement, is not a central
It's not.
requirement in
It's
level
just
4
right.
rules.
I think the only advantage would be from public education to just share the data. That's the only advantage of having more information.
There is another avenue to get data like this or similar from TxDOT. TxDOT collects whether or not the crash was related or alcohol was involved, and they put that in their crash report, and you can request data from TxDOT. We've done that in our RAC. We haven't finished going through it, but it'll have a little box there, was this alcohol related, yes or no. It doesn't say who or what or when, but it does at least tell you what the crash was.
Does it include the driver and the passenger and everybody in the vehicle?
It includes everybody in the vehicle, yes. But the only alcohol-related piece will be of course, the driver piece, so you're not going to get, and that's really all you want anyways, well, I guess, So I think that's another avenue we could look at if that's the type of data we're looking for.
So based on that information, what would you all recommend?
I think if our goal is to find information about the holiday, and I'm not sure that we're going to be able to have complete data for that.
The only thing we'd be doing it for is for public education, to be honest with you.
Jury, I think from where I sit, I think what we're all tumbling to is that you can't address the problem if you're ignoring the problem. And I think that's where we are as a state. And there are some obviously very good reasons for doing that if Texas is one of the states that allows insurance companies to shirk their responsibilities toward the hospitals regarding the expense of taking care of these folks. Then the hospitals virtually have no option but to ignore that as much as possible so that they don't put themselves out on a financial limb for taking care of these problems. From where I sit, what we ought to be doing as a body is recommending two things. Recommending, number one, that the state of Texas step up to the plate and prohibit insurance companies from using that as a method for denying payment to hospitals. And number two, mandating that we draw this so that it's not an our choice, it's our responsibility to gather accurate data for the state of Texas so that we'll know what the magnitude of the problem is. Again, just ignoring the problem will not make it go away.
Right. Strong recommendation. So we have one recommendation to get TTAF involved for education. So do we want to follow through with that recommendation based on Lori's question?
See, we need better data since only 55%. So as a RAC, I had no clue this survey went out to even push my trauma centers to respond. They attend a whole bunch of meetings that they could have got on my computer and answered the survey if they were having a firewall issue. I'm not sure that the statistics are going to change much, but 55% of the total designated facilities is right. I agree. So I'm saying we would help get that information out to ensure that
We had to change over an email
And since today it's not an essential criteria for level 4s, we were just earlier talking about the rule revision, rules being open, is it something we would want to consider changing to essential criteria?
Not if they have to do it as a send-out.
No, essential criteria, they have to be able to do it there.
I guess the thing that probably is the most reasonable action item is to follow Dr. Ryan's recommendation, is to fight the legislation to say they cannot use that as a barrier or a denial for claims. Because if that was the issue, and I have two sides of the house that I live in. I have the trauma world and there's a burn world. The trauma, everybody gets a blood alcohol. Everybody. I don't care how old, how young, whatever. If you're a trauma patient, you're trauma activation, you get a blood alcohol. And in the burn world, Gary Purdue, God rest his soul, refused to allow anyone to draw blood alcohol on a burn patient. And the reason he did that is because of the fear that that patient's insurance would not pay for that. And he thought it was unethical to allow that patient to have such a significant hospital bill that the potentially would not be paid. So I think the strongest action item on the table would be Dr. Ryan's action item, followed by the opportunity for that education I think the research that you guys did is awesome. If there's a way to repeat that, get more information, I think we should do that. And I guess, Christine, the question that I would raise is, this was a big discussion in the meeting in May. So how can we make sure that it does go out? Because we talked about we were going to do it at that meeting. If we send it to the RAC chair, is there a chair of the RAC chairs now? How do we get it to the RACs?
Send it out through the listserv.
Okay.
Give it to Colin.
Okay.
Give it to Colin.
I just want to make sure we're moving forward in the right directions if we're going to do this.
Well, it was sent out through TTAF, so I'm not sure. Some of it I think is firewall, some of it maybe, I know we talked about at TTCF, some issues with change in coordinators, managers, or email listservs or whatever. So I think there's a combination. So if we can try to resend it out, other methods, try to gather as much.
The other thing that I would suggest is, particularly if you're going to move towards legislation, you need to have hard facts about the cases that were denied, not anecdotal things, because sometimes you heard somebody that heard somebody that heard somebody, so you just don't do that because you're avoiding it. So we need to know, really.
And that goes exactly back to my comment, is that we cannot address the problem if we're just ignoring the problem. We've got to have accurate data to know what the situation really is.
We need to partner with the THA and the TMA on this.
Yes, we do.
So lots of discussion. Is there a motion for us to take action on this? Our committee ends at 4 o'clock, is that correct?
Yes, ma'am. Yes.
Well, according to the non-Siri communication, that's in 6 minutes.
Madam Chairman, why don't we entertain a motion that as a body we survey once again all of the RACs to determine if they have documented instances of non-payment of medical liabilities based on alcohol-related blood testing.
THA should be able to do that figure in a heartbeat.
Should be. It may not, David, it may not be specific to trauma, though.
So that's going to be really different, because it's one thing for the survey to go to the trauma program manager. They're going to they're going to respond what they do. I would venture to say that in the level 3s and the level 4s, the trauma program manager doesn't have a clue if there's a claim denied. Is that correct? So I think your point about going to THA or another resource to try to get that information would be critical. So the recommendation should be that we do that. We'll have to do some research on where we go to get that data. Okay? Is that clear for your motion?
That's perfect. Thank you.
So any other discussion? I mean, a second?
Second.
Any discussion on that? All those in favor, please say aye.
Aye.
All those opposed? So that brings us down to, I'm just going to go straight to open comment. A lot of discussion on the registry today. I'm sorry you can see the whole PowerPoint. There was a lot of additional data in there, so we'll try to get that back for the next meeting. Any discussion from anybody in the audience from open discussion?
Thank you. I'm Wanda Helgeson from Border Rack in El Paso, and I would be very interested for this committee to put a standing agenda item to talk about regional performance improvement. How we work collaboratively, best practices from one area, a place where somebody could come and, you know, we're trying to look at this. Does anybody know how to do that? I think that would be very helpful as we move forward.
Anybody else have any public comment? When Wanda talked to me about this yesterday, and I told her, so why don't you come and bring that up in public comment? And at the same time, I just want to remind everybody, so when we went through all the rule revision, right behind the rule revision, we also wrote a trauma system performance improvement plan for the state. That was in draft for several months. It was finally passed in August of 11. With the intention that it would start in January of 2014. And the reason for that variance for that year was for people to be able to start capturing the collect data, get the right data elements into their registry. Some people were buying new registries, and of course, the state registry was an issue. So I can send that back out. We even had tools that went along with that. So some of the committee members that worked on that are gone. We have new committees, and some of us are still here. But I'm happy to share that so everybody can look at that. So I will send that back out. It will be on the agenda item for the November meeting. And then I'll ask for a motion to follow through with what Wanda recommended. Does there anybody else have any comments? We have 2 minutes left. Is there a motion to follow through with what Wanda recommended? Do you want to state what you said again? What your goal was? I wrote it down.
Well, then you can restate it.
Well, your recommendation was that we would have a regional performance improvement standing agenda item on the committee moving forward. So people can share and discuss. Is there an action item on that? We have a motion from Ms. Lori.
No, second.
Second from Dr. Ryan. Any discussion from the committee members?
That's only for racks, right?
Yes.
Racks.
And it's like best practice type.
Or it could be individuals that have issues with implementation of the plan.
It might be for somebody who has the worst practice.
Well, performance improvement implies that we're going to go over issues that your rec has as well. Is that what you intended?
The issues for the RAC.
It could be.
We tried to have this discussion in multiple fronts, and it never takes off. So Jory, being the wonderful trauma queen that she is, we thought could help us with this process.
Probably on purpose, the RAC chairs committee too, the RAC chairs meeting.
Just to lay it out there.
I'm pretty good with that, but I'm not very good with electronics, as evidenced today. Okay, so we will add. We have a motion, a second. Any other discussion? All those in favor, please say aye.
Aye.
Anyone opposed, please say aye. I'll take the opportunity to ask for a motion to adjourn the committee.
So moved.
Second. We're done.
We're just talking about whether